Good evening, everyone. I wanted to thank you all for taking the time to attend this evening's webinar regarding pulmonary presented by interventional radiologist Dr. Peter Lokken from the University of Illinois in Chicago. My name is Sylvan Kraus, and I have with me Pradeep Goyal, Justin Shaffa, and Adam Sutra from the Vascular Disease Service Line, serving as your moderators for this evening's presentation. I would like to especially thank Dr. Peter Lokken for taking time out of his busy schedule to prepare this wonderful presentation and talk with all of us about the diagnosis and management of acute pulmonary embolism in regards to interventional radiology. I'd also like to thank the RFS Communications Committee for advertising the event and handling the logistics of this webinar. This webinar will be recorded and available for viewing later on YouTube. Just for logistical purposes and time constraints, please save all questions and direct them to Justin Shaffa after the broadcast. All right. So I'm just going to introduce Dr. Peter Lokken. He's a vascular interventional radiologist at UT, serving as an assistant professor of radiology. He completed his medical degree and Master's of Public Health from Harvard Medical School. He completed his residency at Brigham and Women's Hospital and his fellowship in vascular interventional radiology at UCSF. So everyone sit back, relax, and enjoy the presentation. I'll be now turning it over to my colleague, Pradeep.
Good evening and welcome everyone. I'm Pradeep Goyal, third year radiology resident from St. Vincent Medical Center, Bridgeport. As Sylvain said, I'm a member of Vascular Disease Service Line under RFS section, and I'm very excited for tonight's webinar on thrombolytics in acute pulmonary embolism. As we all know, acute pulmonary embolism is a common and sometimes fatal disease with a highly variable clinical presentation, because of which a large number of patients remains unrecognized at the time of presentation. So it is critical not only to make early diagnosis, but timely initiation of management so that recurrent thromboembolism and death can be prevented. For years, there have been lack of data how to manage pulmonary embolism patients, but over last few years, there have been some development, including guidelines from American Heart Association and European guidelines for the management of pulmonary embolism patients. In today's webinar, a goal of the webinars are to understand low risk, intermediate, and high risk that Dr. Lokken will describe in detail. After that, he will discuss the evidence for systemic lysis for massive and submassive pulmonary embolism, and then we'll go over pathophysiology and evidence behind catheter-directed therapy for submassive pulmonary embolism. In the end, he will discuss techniques for catheter-directed thrombolysis, basically the current and recent techniques, and he will discuss some of the limitation for mechanical thrombectomy. So before I so now, as you already mentioned about if you have any question, just write down in the question back next right to you on the go to webinar control panel, and then we will discuss later in the end. And also don't forget to check RFS webinar regularly for upcoming events, and try to follow us on Twitter and Facebook for other updates and posters and other educational material cases. Now, without doing further ado, I hand it over to Dr. Lokken. Dr. Lokken, thank you very much for being with us for tonight's webinar. Now you can share your slides here.
Okay, thanks Pradeep, thanks Sylvan. Hey everybody, thanks for listening. I'm just going to talk about PE here for a little bit. Let me just put up my slides. Can everyone see that okay? Sylvan, Pradeep, does that look good?
Yeah, it looks great.
Yeah, looks good.
Good, okay, and you can see the whole slide?
Yep.
Great, okay. So I'm going to talk about PE with kind of a focus on thrombolytic therapy. Going to start off with a few questions here. So what are the three risk stratification categories for acute PE as defined by the American Heart Association? Second question here is true or false, when you read a PE protocol CT, a saddle embolus should be described as massive to expedite and direct management. last question. So after you diagnose an acute PE, the RV to LV diameter ratio should be A, specifically discussed with the refer, or B, buried in the report with less important details. All right, so PE is really common. It's the most common cardiovascular disorder after MI and stroke. Mortality remains high. It's about 8% overall. And it's the third most common cause of death among hospitalized patients. Death is usually from progressive right heart failure that leads to cardiovascular collapse. So when you have a PE, you have increased pulmonary vascular resistance, and that makes the right ventricle prone to ischemia because there's more wall tension. On the other hand, you also have right heart dysfunction with hypokinesis and dilation, and so that leads to less RV output. In turn, you get less LV output. That leads to hypotension, and then there's less coronary artery perfusion, and so there's less O2 supply to the right heart, which is already prone to ischemia. That leads to more hypokinesis, leading to kind of a spiral or a circle of death here. I think that one of the main take-home points from this slide is that someone who appears stable, has normal blood pressure, if they have evidence of right heart dysfunction, they're at risk for going down this death spiral, and so right heart strain needs to be taken seriously. Survivors of acute PE are still at risk for adverse sequelae, for example, residual pulmonary hypertension or dyspnea, exercise intolerance, and in about 2 to 4% of people, CTEPH, for chronic thromboembolic pulmonary hypertension. The picture over there is a pulmonary endarterectomy specimen, and it just shows the white chronic thrombus that's just packed these PAs bilaterally, causing severe symptoms here. So this is the AHA, or American Heart Association, risk stratification categories. The three categories are massive PE, submassive PE, and low-risk PE. Massive PE, this is the highest acuity. It's an acute PE that has sustained hypotension, and the short-term mortality is 50%. These are some of the sickest people in the hospital. The next category down is submassive PE. These patients have preserved blood pressure, but they have evidence of RV dysfunction or myocardial necrosis. Their short-term mortality is somewhere between 3 and 10%. The final group is low-risk PE. These patients don't have right heart strain. They have they're hemodynamically normal. These patients have an excellent prognosis with heparin alone, or actually anticoagulation alone, I should say. Going back to massive PE, so what is sustained hypotension? The AHA defines it as systolic blood pressure of less than 90 for at least 15 minutes or requiring pressor support, and it shouldn't be due to a PE such as sepsis. Submassive PE, again, these are patients that have preserved blood pressure but evidence of RV dysfunction or necrosis. There are several ways to establish a diagnosis of RV dysfunction. One of them is echo. You can see an enlargement of the RV compared to the LV, or you can see systolic dysfunction. On CT, you can also determine if there is right heart dilation. You can calculate the RV to LV diameter ratio. If it's greater than 0.9, it's abnormal. You can also diagnose right heart strain according to the AHA based on certain EKG changes and also laboratory abnormalities. So in the setting of an acute PE, BNP of above 90 is diagnostic for right heart strain, and elevated troponin can also reflect myocardial necrosis. So several ways to diagnose right heart strain in the setting of PE. The AHA guidelines came out in 2011. A more recent document is from the European Society of Cardiology from 2014. They have three categories: high, intermediate, and low. High in the red bar on top is analogous to a massive PE. These are patients that have hypotension. Intermediate is like submassive PE, but there are a couple of important differences. One is that patients need to have an elevated PESI. I'll talk about that on the next slide. And they further stratified that intermediate group into two categories: intermediate low and intermediate high. What they're trying to do here is refine, in the AHA guidelines, there's kind of a wide spectrum of acuity. in submassive PE. Some patients just have slight RV dilation, but are otherwise doing just fine. And then other people have RV dilation and are on a non-rebreather and extremely short of breath and tachycardic to the 130s, and their blood pressure is like 100. These are people who are decompensating. So I think the ESC guidelines are trying to further refine our risk stratification by splitting up that intermediate category. This is the PESI, or Pulmonary Embolism Severity Index. The original version was or is a little complicated. You accrue points based on a number of factors. The classes are then, and when you add up those points, you assign a class. The lowest class, or class 1, has a low 30-day mortality risk of less than 2%. The class 5 patients have a high mortality risk of somewhere between 10 and 25%. The simplified version is also useful. It's obviously much easier. Just one of these things needs to be positive, age greater than 80, or for example, a pulse rate greater than 110. And just one of those points ups the patient's mortality in 30 days from about 1% to 11%. The take-home point for when you're reading PE protocol CTs is that the risk stratification is not really based upon the anatomic clot burden. It's certainly important to describe the clot burden, but just be a little careful with the terminology. A saddle PE shouldn't be described as massive, for example, because it doesn't impart the same mortality risk as someone who has sustained hypotension. All right, RV dilation on CT. Turns out this is a really useful thing to tell the referrers. So the reason for that is that it's an independent predictor of adverse outcomes, such as in-hospital death, 30-day mortality, and 3-month mortality, and that's why it's incorporated in the AHA guidelines. The way that you actually measure it is you can do it in the axial plane. Here's just an example right here. You then measure from endothelium to endothelium, about a centimeter anterior to the valves, at the slice that has the largest diameter. So let's say that this slice has the largest diameter of the RV. It's 5.3 centimeters. Again, we're excluding the myocardium here. It's endothelium to endothelium. And then here is the corresponding measurement for the LV. It's 2.8 centimeters. You divide the two, and you get a ratio of 1.9 in this case. So this patient clearly has an enlarged RV to LV ratio. The cornerstone of treatment for PE is anticoagulation for at least 3 months. It's the only therapy that's recommended for patients that have a low-risk PE. And it's huge. It's reduced PE mortality from over 30% that was reported in the 60s or so before heparin was used to about 8% today. It works mainly by preventing thrombus propagation, but an important limitation is that it doesn't actively dissolve existing thrombus. And so it might be insufficient for people who are decompensating. That's the reason why people have been investigating treatment escalation for higher risk patients in order to rapidly reduce clot burden and right heart strain. And the most thoroughly studied way to escalate treatment from anticoagulation is thrombolysis or fibrinolysis. That can be delivered in 2 different ways. One is systemically through an IV, as is done, for example, in MI or stroke. The second way is catheter-directed thrombolysis, where you have a catheter in the PA and administer a thrombolytic agent that way. Just briefly, I'm going to talk about how thrombolysis works. Here is the coagulation pathway. You have the intrinsic pathway and the extrinsic pathway. They both converge at a final common pathway where prothrombin is converted to thrombin. And in turn, fibrinogen is converted to fibrin, and that is clotting. Clotlysis, on the other hand, is when you administer either alteplase or tenecteplase, some other TPA, that converts plasminogen to plasmin, and that in turn dissolves clot. What is the role of thrombolysis in clinical practice? The most established role is in massive PE for patients who have a low bleeding risk. The recommended way to do thrombolysis, just 1 second, my phone is blowing up for some reason. 1 second, sorry. All right, sorry about that. Yeah, so for patients with a massive PE that have a low bleeding risk, the current guidelines suggest giving systemic thrombolysis. The reason for that is that it reduces all-cause mortality and recurrent PE. The most common protocol is 100 milligrams of TPA over 2 hours, and this is supported by essentially all major society guidelines. Unfortunately, systemic thrombolysis comes at a cost, and that cost is bleeding. The rate of major bleeding has been described as up to 20% or over 20% requiring transfusion, and intracranial hemorrhage, probably the most feared complication, has been reported in up to 5% of patients. The bottom row is a meta-analysis of all thrombolysis studies, and this includes people with submassive as well as massive PE, and the overall rate was 9.2% of major bleeding and of intracranial hemorrhage of 1.5%. So giving TPA is serious business. So what is the role of thrombolysis in submassive PE? So you might be asking yourself, why in the world would you consider thrombolysis for someone who's normotensive and may do okay with anticoagulation alone, given the bleeding risk? The reason for that is RV strain elevates the risk of acute decompensation or death. Those combined endpoints occur in about 6% of patients who have a submassive PE. And patients who survive with anticoagulation alone often don't do very well. They often have evidence of sustained RV dysfunction. And that's reflected in exercise intolerance, residual pulmonary hypertension, and lower quality of life and perception of wellness. So that's the rationale behind treatment escalation in submassive PE. It's been evaluated in at least 16 prospective RCTs over the last 25 years. I think most recently was the PITHO trial from 2014. That evaluated systemic tenecteplase, and that was shown to prevent death or hemodynamic decompensation. It occurred in 2.6% of patients in the tenecteplase group versus 5.6% in the anticoagulation alone group. But it came at a cost of increased risk of major extracranial hemorrhage, 6.3% in the tenecteplase group versus 1.2% in the anticoagulation group, and stroke, 2.4% in the lysis group, and 0.2% in the anticoagulation group. I've included the MOPIT trial here mainly because it looked at longer-term endpoints. So 28 months, a lower dose of TPA reduced the incidence of residual pulmonary hypertension and recurrent PE compared to anticoagulation alone. So lysis does appear to help with short-term outcomes and some longer-term outcomes, but it does come at the cost of more bleeding. So there were about 3 meta-analyses of lysis in submassive PE, and one demonstrated a decrease in overall mortality from systemic lysis. I think they all showed a decreased rate of clinical deterioration, and they all showed increased risk of major extracranial bleeding or stroke. So how can we realize the benefits of fibrinolysis while minimizing the bleeding risk? And this is the rationale behind catheter-directed thrombolysis. So catheter-directed thrombolysis is performed by putting 1 or 2 catheters in or adjacent to PA thrombus, and then giving a lower dose of TPA or other thrombolytic agent. In the case of TPA, administering at about 0.5 to 2 milligrams per hour for a total of 15 to 30 milligrams. So that's about a third of the dose as given systemically, and it's given over a longer time period. Does CDT help anyone? Well, there was a randomized controlled trial, the Ultima study from 2014, that prospectively evaluated ultrasound-assisted thrombolysis. That's ECOS. I'll talk about that in a little bit. 10 to 20 milligrams in one group versus heparin alone. They got 10 to 20 milligrams of TPA over 18 hours. They were evaluated at 24 hours. In the CDT group, there was a reduction in the RV to LV ratio, whereas there wasn't a decrease in the heparin alone group. The mean PA pressure reduced in the CDT group, and there was less RV dysfunction in 90 days in the CDT group. The PA pressure reduction has been corroborated in several, in the prospective Seattle 2 single-arm study, and also the PERFECT registry. The PERFECT registry is kind of a real-world prospective experience where I think there are about 15 participating centers who prospectively enroll patients and then send their results to Stanford. And the initial 100 patients were published in Chest in I think 2015, and among other things, it showed a reduction in PA pressure that's analogous to the other prospective trials. And also numerous retrospective studies have shown a similar PA reduction. I've just included the University of Illinois experience here. We looked at it based on the amount of TPA given and saw that the more TPA we gave, the lower the PA pressure we achieved. What about bleeding? There appears to be less bleeding risk with CDT. The top row here is a meta-analysis from 2009. This included patients from the 1990s onward when we were using bigger catheters and treating sicker patients. So most of the patients in this meta-analysis have massive PEs and were at higher risk for adverse outcomes. Even so, the major bleeding rate was 2.4%, which is less than the systemic lysis studies, and intracranial hemorrhage less than 0.2%. The second row down is the PERFECT registry initial experience, a more modern experience, treating mainly submassive PE, and they didn't report any cases of major bleeding or intracranial hemorrhage. And contrast that again with the meta-analysis below by Chatterjee et al. From 2014. 9% rate of major bleeding for systemic TPA and 1.5% intracranial hemorrhage. So what's the role of CDT in submassive PE? So it appears that CDT reduces PA pressure and RV dilation with a low bleeding risk, but there's a lot of uncertainty about the benefit of CDT overall because we don't know if it impacts rates of hemodynamic decompensation or mortality. We haven't evaluated longer-term clinical endpoints such as exercise intolerance, residual pulmonary hypertension, recurrent VTE, and how it affects quality of life and perception of wellness. And certainly we haven't evaluated if it's cost-effective because we don't know what a lot of these clinical benefits are at this point. Overall, there's insufficient evidence for recommendation of CDT for submassive PE and guidelines. So when do we perform it? In our experience, and I think a lot of other centers too, we usually are consulted for CDT for sicker patients who have a submassive PE, people who appear to be kind of teetering on decompensation. In guidelines, there's a weaker recommendation for systemic lysis for these patients, but if you put yourself in the shoes of the ICU attending or pulmonologist, they're understandably reluctant to give systemic lysis to someone who's pretty stable, who may do okay with heparin or CDT, because it's hard to stomach that 10% risk or 9% risk of major bleeding or a possibility of stroke. There is a role of CDT for massive PE in the ACCP guidelines from 2016. They recommend consideration of catheter-directed therapy in patients who have a high bleeding risk or have failed systemic thrombolysis or have shock that's likely to cause death before thrombolysis can take an effect, for example, within a couple hours. And I think what they're mainly referring to is mechanical options for thrombolysis, which I haven't really discussed yet here. I'll talk a little bit about CDT technique now. So we start by putting in a PIC that it's much more comfortable for patients because they need to get frequent blood draws during CDT for monitoring. And you also avoid some of the venipuncture complications, so people, poking needles into the skin when someone is receiving TPA. And it's also a way that you can administer heparin drip. Then we perform diagnostic angiography. You have a number of options for venous access. You can either do the groin. I tend to, when we do the groin, we usually do the greater saphenous vein just to avoid puncturing the deep venous system. You can also certainly do the common femoral vein, and then IJ access is also an excellent option. Then catheterize the main PA, and there's numerous ways to do that. When we come from the groin, we typically use a Van Amen catheter. It's a 7 French catheter. It has a 90-degree curve before the distal 5 centimeters. And what that helps do is that when you bring it up from the IVC, as it gets to the right atrium, it pops into the right atrium. And if you advance the catheter while turning it towards yourself, it will often pop into the pulmonary outflow. That's just one of many ways to catheterize the PA. And then perform diagnostic angiography. Then start CDT. So you can have either 1 or 2 catheters in the PA. You can have a unilateral catheter, or you can have bilateral catheters. Either is acceptable. And then give TPA or some other agent. For TPA, 0.5 to 2 milligrams per hour has been described in the literature. Can give concurrent heparin. A lot of centers give subtherapeutic heparin of 40 to 60, goal PTT of 40 to 60 seconds. We happen to historically keep it at a goal of 60 to 80 seconds. And then the patient needs to be monitored in the ICU during CDT to look for evidence of sentinel bleeding, like a nosebleed or ear bleeding, a hematoma at the venous access site, and also blood, check the stools for blood, check urine for blood, stuff like that. And we draw labs every 4 to 6 hours for CBC to mainly look for the decrease in hematocrit, a PTT to assess the rate of heparin, and also fibrinogen to make sure that the stores aren't too depleted. Then at some point you need to end CDT. I wish I could tell you there was a right answer or a definite right answer of when to stop CDT for every patient, but I'm not sure we know at this point when to do that. One option that you can do is just mimic a trial protocol. You can do the Ultima or Seattle 2 protocols. You can also titrate it to symptomatic improvement. Maybe someone was on a non-rebreather and now they're on 2 liters nasal cannula. Another goal is normalization of PA pressure, and you may consider trying to eliminate the central clot burden. My personal feeling is that it probably isn't worth the risk and expense to get rid of every single bit of clot in the PAs. My personal philosophy is generally to try to convert somebody from a submassive PE situation to a low-risk PE patient so that they can be treated with heparin alone and have a good outcome. Obviously, this has to be balanced with the bleeding risk of the individual patient and also the progress of the procedure if you're having an impact on the PA pressure. What infusion catheter should you use? Well, there's several techniques described, and at this point, none has been proven to be better for all situations. On the bottom left there are 2 conventional infusion catheters. There's radiopaque markers on these catheters, and between them are numerous holes. So if TPA solution through the catheter, it kind of goes out these holes like a little sprinkler into the clot. And they position both of these in the lower lobe pulmonary arteries. The middle one is the ecosonic ultrasound-assisted thrombolysis catheter. The radiopaque markers there are actually the ultrasound transducers. And then you can also use a pigtail catheter, either 1 or 2. In this case, there are bilateral pigtail catheters being used to deliver TPA. I'll talk briefly about ultrasound-assisted thrombolysis and try to compare it as best I can with a conventional catheter, given what evidence is out there. So ECOS was used in both the Ultima and Seattle 2 prospective trials, probably the 2 most important trials of CDT yet. It's an attracted device. It is purported that the ultrasound disaggregates uncross-linked fibrin and increases its permeability to TPA. And the hope is that allows you to, A, decrease the amount of TPA that you give for the same effect, and also accelerate the process of clot dissolution. And it's FDA approved for PE. One thing to note, though, is that the benefit of USAT over conventional infusion catheters has not been established in clinical trials. In the PERFECT registry, they compared experiences with conventional infusion catheters and ECOS catheters, and they couldn't discern any advantage. And there was a recent article in JVIR, I think from last month, that they compared USAT with using bilateral pigtail catheters alone, and they weren't able to discern a definite difference either. And ECOS is actually pretty resource intensive. The catheters are, I think, well over $1,000. That's my understanding, and whereas like a pigtail catheter is about $80 or so. So there may well be a benefit to ECOS and PE, but as a value-driven measure, we haven't adopted it for PE, and I feel like we're justified in doing that. I think if you're considering ECOS, I'd also encourage you to read the Bernudafol trial. This was a prospective randomized controlled trial of USAT versus conventional CDT. Note that there is not such a trial in the setting of PE, but this information is useful. In one arm, they had ECOS turned on, and the other one they had it turned off. And so the one where the catheter was turned off was basically a proxy for just a regular infusion catheter. They gave 20 milligrams of TPA over 15 hours, and they didn't see a difference in any of their endpoints. So it was a negative study, and I think it adds a little bit of skepticism as to whether ECOS should be adopted. Jury is still out. Talked a lot about thrombolysis. One thing I should have probably mentioned earlier is what are some of the contraindications of thrombolysis. There's a number of things to consider. You know, this is kind of the board's answer. One thing that, and I'll just let you read the slide yourself, but I think one thing is that you kind of have to be reasonable. So if someone has had a diverticular bleed or something 2 months ago and it was clipped endoscopically, and now has a massive PE or severe submassive PE, it's worth considering doing catheter-directed thrombolysis because you can probably fix a GI bleed, but maybe not resuscitate a patient who codes. But there are some situations where it just really isn't right to give TPA, and I think the most common scenario we encounter is someone who's had recent intracranial surgery or else has like intracranial hemorrhage. These patients really can't get lysis, and that's where I think mechanical thrombolysis shines. We typically reserve it for patients who again have really high bleeding risk or a massive PE with impending RV failure and death. It would be great to be able to use it in everybody, but it just seems like we're still searching for a catheter or system that's acceptably safe and effective for this to be used in everybody. I'm going to talk about just a small assortment of techniques for mechanical thrombolysis. There are a number of them, other ones out there. I encourage you to read about it, but these are just a few that I'm familiar with. Some of them I've used. For mechanical thrombolysis, probably the number of ways to do it. For example, just to put a balloon in the PAs and expand it to try to macerate the clot. The rotational pigtail technique got a lot of attention in the 2000s. What you do is you rotate a 5 French pigtail around the axis of a guide wire. So this hole here at the tip of it, I'm not sure if they sell catheters like that, but you kind of have to make it yourself. In my experience, and you need this too. If you don't have the scaffold of the wire in there, it's pretty much impossible to achieve the torque you need to have an impact on the clot. You can use a bigger loop for central vessels, 12 millimeters, or a smaller one for lobar vessels. This was evaluated in a prospective trial of 20 patients with massive PE. 15 didn't have any adjunctive TPA, and the researchers reported a decrease in shock index, mean PA pressure, and angiographic store. Just the shock index is just the heart rate divided by the systolic blood pressure, by the way. So why don't we do this all the time? The reason is that the rationale behind mechanical techniques like this is that the surface area of the central vessels is smaller than when you add up all the surface area of the peripheral vessels, and so if you can make the clot small and go to the peripheral bed, there might be less pulmonary vascular resistance. I think one problem though is that's not really what we're achieving with these techniques in general. You're kind of going from a big thrombus, in this case one that's lodged just past the bifurcation there, and you have a huge thrombus that you're breaking up into big pieces, and so you end up with macroembolus. and the results can be unpredictable. So soon after that prospective study came out, a number of case reports came out, like this one, for example, where they started with a lot of clot, but there is preserved perfusion, for example, in the upper lobe, and it's attenuated but present in the lower and middle lung zones. And then after, there's no perfusion, right? So there was a macroembolus that swung up into the upper lobe pulmonary artery, and also appears to have blocked off the branches of the lower lobe and middle lobe. And no perfusion, the patient started to decompensate on the table. So fortunately, they were able to resuscitate this patient, but this is the reason why, for example, we don't do it routinely in submassive PE. Results can be unpredictable, unclear benefit. Moving on to suction thrombectomy, it would be great to be able to suck out clot, it'd be perfect, but it's a challenge to do that. You can attempt to do that with any end-hole catheter, like an 8 French sheath, for example, but it needs to be big enough to be able to evacuate organized thrombus. And when you start sucking on a tube in the PA, you're gonna take blood out, and so until you're able to make contact with the clot, and so you have to be cognizant with the amount of blood that you're removing. There are several devices on the market. These are just a small selection. I'm not recommending them over other ones. I'll start talking about the Indigo, then there's a picture of this on the right there, and then flow retriever, and AngioVac. And okay, so here's the penumbra. So it's an 8 French outer diameter catheter. The inner diameter is 6.7 French, and it's advanced through the PA or into the PA via an 8 French sheath. And there's a separator wire that you can see. Hopefully you can see my arrow. Maybe you can't. Right here. So that's a mobile separator wire that you kind of pull back and forth to try to break up clot that's stuck to the tip there and have it break up enough to get sucked into the tube. And this is just a drawing. You can see that you can have some with different angles. And then you could connect it to a vacuum. There's a little a flow switch here, so that if you're withdrawing blood and you're not, which means that you're not contacting thrombus, you can just turn it off to minimize blood loss. The largest published experience that I'm aware of to date is 6 patients with submassive PE from Miami Vascular. These patients all had a contraindication to anticoagulation. They reported a decrease in systolic PAP and a decrease in RV to LV ratio. They didn't specifically report their EBL, but they did see a trend of a decreased hemoglobin. Not statistically significant, but there's no question that you have blood loss with this device. It's just part of it. So promising. This is a great case that they published. So when you look at the angiography of the PAs, there's kind of 2 main things you look at. One are filling defects, for example, here in the lower lobe pulmonary artery, and then also in the upper lobe up here. And then you look at perfusion. So you can see the pretty uniform perfusion in the upper and mid lung zones, but pretty much severely reduced perfusion in the lower lung zone. They've guided this 8 French catheter into the right lower lobe pulmonary artery. Here's the separator wire. And afterwards, there's still clot there. So you can see this this large thrombus here. And you can see some thrombus in the lower lobe, but perfusion is much better than before. They didn't report the PA pressure or for this specific case, but it sure looks pretty good on imaging. There's a clinical trial that's pending for this device. Here's the flow retriever. So I have not used this device. This picture, though, doesn't really do it justice in terms of how big it is. This purple sheath is 20 French, so that's almost 8 millimeters in diameter. It's a big device. Through that is this white sheath is 12 French, and that can sheath these 3 expanding nitinol discs, which are kind of like amplastor plugs. At least that's my understanding. And you deliver them sheathed over a guide wire, and then you unsheath these amplastor type nitinol discs. And the hope is that the clot will kind of stick to these as you pull back this lever, which simultaneously aspirates and also withdraws the clot and discs into the 20 French sheath. After that, the entire device is removed. There is a prospective clinical study going on. Right now, there's only case reports. This is a case report from JVIR this year. You can see that there is a thrombus in the left lower lobe pulmonary artery with reduced perfusion. You can also see some reduced perfusion here in the mid-lung zone. This is the 20 French sheath through that. Must be the 12 French sheath that goes over the nitinol discs. These are unsheathed, so you can see them opening up here, expanding to the width of the lumen. And then they withdrew it. You can see that there's better perfusion, not perfect, but better in the lower lung zone, and probably more importantly, the PA pressure has decreased dramatically, and this is what they were able to get out of there. And then finally, AngioVac. This is an incredible device. It can do stuff that no other catheter that I'm aware of can do. It's very large. It's 22 French, and the tip can expand to 48 French, and it's advanced through a 26 French dry seal, sheath. And because it's so large, it removes blood at a rate of like a liter a minute or more, and so you have to put the patient on veno-venous bypass, returning the blood via a separate infusion cannula that you insert in another vein. As it goes through that veno-venous bypass, it goes through the blood goes through a filter, and the clot that you take out accumulates in that filter. One important thing to know is that the patient needs to be fully heparinized during the procedure because of the bypass. And this device, I think, is mainly designed and used for IVC thrombus or right atrial thrombus in transit. It's a stiff device, and it's difficult for it to make curves. But people have tried to use it in PE. There are a number of case reports and case series. The largest one I'm aware of is from UCLA. 5 patients, 4 of them had a massive PE, and the outcomes were not great. The 80% died about a week after the procedure, and one sustained a right ventricular perforation, which I think reflects the stiffness of the device and the difficulty of making those turns. This is a nice case that they showed. It's a patient who had, I think, metastatic RCC into the IVC, and during surgery, the tumor thrombus embolized to the PA system, and so you can see the absence of perfusion at the mid and lower lung zones there. This is the AngioVac, so they've done an IJ approach. Here's the dry seal sheath going into the right atrium. Through that over a wire with a dilator that comes with the device, they've managed to get the AngioVac around the bend into the main PA. I doubt it's possible to get this further than that, and so what they've done is they've gotten a separate access with the groin here, and they've put a balloon catheter distally, probably in the lower lobe pulmonary artery. They've inflated it, and now they're drawing it back so that the thrombus goes to the AngioVac catheter. And this is a similar approach that you can use like when you're doing IVC thrombus with AngioVac. Difficult to get it in the iliacs even, and certainly the femoral veins. And so what you can do is get separate accesses in the legs and push up a clot like with the Fogarty or something into the device. So they managed to restore some perfusion, and this is the tumor thrombus that they managed to evacuate with AngioVac. Finally, I'll touch on rheolytic thrombectomy. For example, AngioJet. The way that works is that it creates a low pressure zone behind high pressure saline jets. It jets out saline from the front of the catheter at something like 360 miles per hour, something just incredible like that. And then that creates a low pressure zone behind it, and thrombus is then sucked into the catheter. The issue though is that the jets are so powerful that they also lyse RBCs, and in turn the RBCs release adenosine, which you might remember from ACLS is used for supraventricular tachycardia. So it causes bradycardia and sometimes heart block. Also, the lyse cells release hemoglobin. You can get hemoglobinuria, and as a result, AKI. Should be aware that this can happen anywhere that you use this catheter. It can use, certainly in the IVC, also even in the lower extremities, it's been reported. But there's no question that it happens more often the closer you are to the heart. And in that 2009 meta-analysis that I mentioned, they found that there was a higher complication rate with AngioJet compared to other techniques. 28% of the patients had a major complication like hemoptysis, heart block, and death. there were more procedure-related deaths with this device than others when using it for PE. And so based on that study, it earned a black box warning for PE from the FDA. And it's rarely used. Some people advocate for its use in some situations, but you have to be careful and certainly keep an eye on the monitor. I personally have never used it for PE and avoid it as much as possible. So I'm going to kind of stop here. So I talked about the risk stratification categories for acute PE, evidence for systemic lysis for massive and submassive PE, discuss the theory and evidence behind CDT for submassive PE and some of our knowledge gaps, discuss some techniques for CDT, and then finally some current techniques and limitations for mechanical thrombectomy. So thanks for listening. I hope that was useful, and feel free to ask me questions and I'll try to answer them.
All right, thanks,
hey everyone.
Yeah, so before we start with the questions, I just want to let everyone know this recording this lecture is recorded and will be available on YouTube afterwards. So I'll pass it on to Justin and Sylvan and Pradeep here.
Hey everyone, I'm Justin. That was a great lecture, so thank you, Dr. Lokken. I will be leading the question portion of it. I have collected a few questions. If anyone wants to ask anything through the chat or by messaging me directly or by using the question feature, please feel free to do so. The first question we have is about mechanical thrombolysis. Dr. Lokken, you sort of mentioned the individual indications for AngioJet versus rotational suction versus the other options, but the asker was also wondering if you had any personal preference or if your institution had any preference for mechanical thrombolysis.
Yeah, that's a great question. I think our approach mainly is we've used Penumbra. We've had pretty good results with that. I have to be totally frank with you. I mean, all of these devices that I've used so far have limitations, and part of the issue is just that you need to have a big enough device to take out the clot. And for DVT, it's pretty clear. It's often clear how acute, because you can pinpoint when the person started to have symptoms. Just as a reminder, an acute clot is defined as less than 2 weeks old, and then chronic is greater than 2 weeks. And the reason why that differentiation is helpful is that when it's chronic, it's less responsive to TPA. It's more like tissue. It's firmer, less likely to be sucked out, through a small straw. For PE, I think even though you can often pinpoint when the PE occurred, you can't always know how old that clot is, and so the clot can be firm and tough to evacuate. But the ones that we've used, we try to tailor to the patient. We'll use Penumbra because we have it on the shelf. We'll use balloons. We'll try the rotational pigtail technique, and sometimes we'll just try to give TPA also. But I haven't used AngioJet in the PAs, and I'd be interested to know if anyone else has seen that and if they've had good experiences. But I'm highly reluctant to use that.
Very cool. Yeah, I was actually a surgery intern at UCLA last year, so I know their use of the system. There was actually a big case they did with a right atrial mass that they sectioned out.
Yeah, well, that was probably with the AngioVac. AngioVac is awesome. I mean, it's incredible. I mean, the RA thrombus is kind of a more established. A lot of cases have been reported with success, and you can kind of see why. I mean, it's a straight shot from either the groin or more often the IJ. People have there was a recent article on steaming the catheter, so it has a little curve on it, so you can direct it more in the RA. But it's a stiff device. It's hard to make that turn around into the PA. One thing that's important to know is that when you put in the PA or anything that's large like that, you probably want to float a swan or something, or else use a pigtail to get into the pulmonary outflow tract. If you just use a guide wire, you can go between a chordae tendineae, and as you dilate over that 22 French or whatever, you can blow out the valve. And so that's one cautionary note also with using big devices through the heart.
Yeah, I was speaking to the cardiac surgeon involved in the case. I guess the that patient outcome wasn't too good, as you were alluding to. They didn't make it out of the hospital stay in the end.
Yeah, that's too bad.
Uh, Moving on to the next question, you sort of alluded to acute versus chronic PE. The asker is a med student, just wondering what the basic findings to differentiate acute versus chronic PE are.
Yeah, that's a great question. So I think oftentimes it's CT is really useful. So an acute PE has the classic tram tracking sign where there is clot partially occluding the vessel. It's in the center, and there's contrast all around it. A chronic PE, as it starts to organize and dissolve, at least partially dissolve, tends to become more web-like and adherent to the wall. So that can be one signal that it's a chronic PE. And unfortunately, those don't respond as well to lysis as others.
Okay. I had a couple of questions comparing CDT to systemic thrombolysis.
Okay.
First one, are there any localized complications in the pulmonary artery regarding CDT use?
Yeah, that's a great question. So it probably depends how you do it. If you put well, I guess there's a couple of ways to look at it. So in our experience, not so much. The way we do it is, what I should say is that we haven't detected any. Once you get through the RV at RA, I think it's unusual to have a significant arrhythmia, at least in our experience. I mean, you certainly can when you're trying to get through the heart, but afterwards, things tend to settle down. Having catheters in the PAs does have risks. One of them is causing like a PA pseudoaneurysm, for example. But if you're just putting, if you're careful with your technique in the sense that you use like a Rosen wire, something with a loop on it, so that it has a blunt tip, that's less likely to happen from a wire injury. I've certainly heard of people perforating into the lung using a straight wire. And then also just the kind of catheter you use. So if you have a pigtail catheter, I think it's difficult to get far enough to cause problems or put enough pressure on the wall to cause problems. Yeah, I mean, yeah, you certainly can cause an injury, but I think a lot of it is if you kind of are careful with your technique, it's a little bit unusual. Complications are common with CDT. Don't get me wrong. I mean, but the most common ones are bleeding from your access site, in my experience, or from venipuncture locations. Sometimes hemoptysis. We've had that a couple times. It's been self-limited, but we haven't had any PA pseudoaneurysms or ventricular wall perforations or anything like that just from catheterizing the PA.
Okay. Yeah, that also answered our next question, any complications that you have come across personally.
Yeah, that's a great question. I can speak to that some more. So we reviewed our experience recently, and we had, so there's a bleeding classification. The one issue with these trials is they don't always use the same one. Seattle 2 used Gusto, and Gusto is there's 3 categories. One is clinically insignificant, basically no need for transfusion or anything. That's like minor, and then moderate requires transfusion, and then severe is either life-threatening or cause death or something like that, or disability. We didn't have any major ones. We had a number of minor ones, and again, it's usually oozing at the site of sheath entry into the vein, or self-limited hemoptysis or something like that. But I encourage you to look at the trials out there like Seattle 2. Seattle 2 had a lot of moderate bleeds, which that was one thing that's unusual about that study. Raises questions about how they're actually accessing the vein, whereas Ultima didn't, Perfect didn't really. So, but those are good ones to read. If you had to read 3 articles, it'd probably be Ultima, Perfect, and Seattle 2. But also Aki Sista wrote a nice review in Radiology just last month on PE. That's an excellent review, and I'd encourage you to read that one too.
Okay. We have a great question from Dr. Vatican Cherry out of LA. He is asking about clinic follow-up. When do you bring patients back to clinic and how long do you follow them for? What anticoagulation regimen do you put them on and for how long? And lastly, about repeating echoes after thrombolysis.
Yeah, that's a great question. So there's a whole separate set of guidelines for how long to have somebody on anticoagulation and for provoked versus unprovoked PE and stuff like that. And usually what I do is I defer that management to the hematologist. I tend to see the patient in clinic 3 months later, and we get an echo at that time too to see outcomes. And that's also an opportunity if someone had an IVC filter to make sure it's out, stuff like that. So we see them in clinic about 3 months later with an echo.
Okay. Do you find that you're mostly in charge of the anticoagulation regimen, or is it on the primary team?
I try to work with them as a team. I mean, I think that you know, when we're doing CDT, that's when I kind of take control, just to make sure that the heparin level or the PTT is at a safe place. That's kind of when I take control. But then after that, I kind of like loosen the reins a little bit and you know, let them if they want to do a hypercoagulative workup and stuff like that, or if they want to use a newer oral agent or something else, depending on the patient's situation. You know, if they can, you know, there's a lot of factors I think that go into choosing a specific therapy, and so I typically let medicine help with that.
We have a question by Nabi Diab. He is asking if you would ever use a combination of fibrinolysis and mechanical thrombectomy for massive PE. And second part is, do you put the patient under general anesthesia if you're doing using the penumbra catheter?
No, I don't really put someone under GA for this. I think that having someone in GA can cause hypotension and problems, may not be safe for the patient. The procedure typically isn't very stimulating. It's really the puncture site, the lidocaine at the puncture site that's most painful, or else if they have a back problem lying on the table. The massive PE patients are super sick. I mean, they're just like basically dying in front of you, and so you know, like basically, oftentimes what happens is you know, we're called to the OR or something because they think the patient has a PE, the patient's already intubated and stuff like that. We'll just do angiography and try to salvage. We certainly will use TPA unless there's a complete contraindication. Whenever possible, use TPA, and if someone is crumping, the TPA needs time to take effect, like probably at least 4 hours or so. So then we'll also use mechanical thrombolysis concurrently in those situations.
Our next question is by Jacob Fleming. He asks about the case volume at your institution, and if you have put forth any efforts to sort of expand that practice. I guess I could add on to that. I guess at UIC, do these cases fall more on IR or more on vascular surgery? I know that differs at different institutions.
Yeah, it just turns out that we do all the PE cases here. I won't get into the whole, obviously it depends on your institution, right? So we do all the PE stuff here, but we work as a team, you know, in terms of, because everyone has a role to play. You know, cardiology helps with the echoes and stuff like that, and the ICU people are the ones kind of in the trenches at the bedside overnight. But we do the catheter stuff. Our case volume has been increasing over the years. I think we did 14 last year, but I don't think that we're treating as many people as we could. I think there's often a bias against lysis of any kind by some pulmonologists. I shouldn't call it a bias because it's a reasonable position to take given the equipoise in the literature. But I think but part of it is probably lack of awareness too. And so one thing that we've been trying to do is just create a PERT team. Been kind of working with colleagues in the ED, cardiology, pulmonology, and critical care to try to kind of get an algorithm for how to manage these patients. And usually the algorithm is just to lead to discussion, like a multidisciplinary discussion. But at least it raises the awareness of of how sick patients with a submassive PE are. First of all, it's just educating people about the risk stratification, right? Second is pointing out how sick submassive PE patients are, even though they are in many ways stable, and then kind of making sure that all the options for each patient can be discussed. So hopefully, when we get this PERT thing rolled out, that will lead to more awareness and maybe more consultations for it too.
Okay. Kirsten Lewis asked a couple of questions. She was wondering if you had any specific use of the Rotola device in terms of mechanical fragmentation, or if that is too traumatic for the pulmonary artery.
Yeah, that's a great question. I've never used it actually for the PAs. I've certainly used it for dialysis grafts, and I think I've heard that you can use it in like AV fistulas without too much venous inflammation and stuff like that. I have to admit, I have not. I don't think I've read about it in the PAs. I'm just trying to think if the ones that we have on the shelf are kind of short, so they probably, because they're designed for dialysis, as far as I can tell. So I'm not. At least the ones we have wouldn't reach the PAs. I'd be a little bit concerned about opening that up. Yeah, I don't. That's an interesting idea. I'm just not sure. I haven't used it, and I'd have to look at the literature to see if that's something that other people have tried. I may be a little bit worried about using it, honestly, but if someone else has used it, I'd like to hear about it.
Yeah, maybe she'll weigh in if she has had any experience. She was also asking if any of the techniques we've discussed tonight have any role in the treatment of chronic PE.
I think there has to be kind of an acute component for it to be helpful, like acute on chronic. For chronic PE is kind of a whole different thing, and like CTEPH is kind of a rare outcome, but thrombolysis doesn't really play a role there because the thrombus is chronic. So I think there has to be an acute component for this stuff to work. If it's old clot adherent to the wall, I think any of the things I discussed probably might not work very well. So I think the role is mainly in acute PE.
Okay. She's wondering if any of the catheters we've discussed tonight can get deep into the segmental or subsegmental vessels.
I'm sure it's possible. Let me kind of go through. I mean, certainly AngioJet could, at least not the Zelante, maybe that's the 8 French one, but the smaller ones. AngioVac certainly can't. I think the short answer is probably no. And then for subsegmental ones, and then the next question is like, why would you do it? You know what I mean? Like, I'm not sure that you need to get that far out. You just need to open up like a lobar vessels and the main vessels to achieve like a pressure reduction enough to stabilize the patient. So usually when people are doing this, I think they're not trying to evacuate every little bit of clot. They're trying to just make a dent in the central and lobar stuff to reduce pulmonary vascular resistance. I wish this was more interactive. I'd love to hear what you guys have experienced and stuff like that, but that's just kind of my opinion. And
yeah.
I wish I could hear if you guys have a different point of view or have heard something else from other practitioners.
Yeah. Anyone feel free to just insert something in chat, and I can read it out for everyone. But for now, the last question I have is sort of just regarding your personal preference. Adam asks, one second, are there any devices that you personally recommend for the treatment of submassive PE? He was referring to a JVR article that specifically talked about ultrasound thrombolysis recently. Okay, yeah, the ultrasound thing, I talked about that a little bit. That's the ECOS thing, and I'm just gonna say I don't really believe in it. I just feel like if it's gonna work, it's gonna work for DVT because the catheter is acute DVT because the catheter is embedded in clot, and the effect of these transducers is local. And
So for DVT, you know, the thing is just bathed in clot, just drills through clot with the wire, and that's the best opportunity for this to work. For PE, let me just try to pull up an angiogram somewhere. Yeah, I guess we could just, the situation often is, and this isn't a good example either, there's a reason why these were good for mechanical thrombolysis, but basically this is a nice example because you can put a catheter in here and it's going to be reasonably close to clot, but oftentimes you have clot kind of at the hilum there, and most of your transducers are going to be proximal or distal to it, and you will have clot in other lobes, you know, that's essentially miles away from the catheter. So I'm not sure why the transducers would have much of an impact. The other thing is that they're not embedded in clot in PE. The PAs are big. You're not drilling through clot. You're following a guide wire that's going to go wherever, which is going to be, you know, adjacent to the clot but not in it. So I feel like I personally don't believe in it at this point, but I'd be open to new evidence if it ever comes out.
Okay. With that, I will turn it back over to Sylvan for closing remarks.
All right, thanks, Justin. So that was a wonderful talk, Dr. Lokken. It was a wonderful presentation, and we all want to thank you for taking your time to speak with us. I want to especially thank the Vascular Disease Service Line and the Communications Committee for putting this all together and making it happen. Again, this webinar webinar was recorded and will be posted on the YouTube page for viewing at another time. And with that, again, just want to thank you again, Dr. Lokken, for speaking with us tonight.
Yeah, thanks everybody. Hope that was somewhat useful, and thanks for listening.
Thank you. Thanks everyone for coming tonight. Have a good evening.
All right, thanks. Good night.